Good morning. This is Dana Parsons. So welcome everyone to the Coronavirus Weekly Member Update. Just want to go over a few things before we get started. As Paula mentioned, today's call is being recorded. It will also be placed on our COVID-19 resource page on our website. We also want to mention that this call is not intended for the media. However, we cannot represent nor guarantee that members of the media are not participating. And also the information that's provided, statements made, and data provided on this call today are for informational purposes only. Okay, so we're so pleased today to have Gary Salmizi, with President and CEO with Westminster Canterbury of the Blue Ridge, to talk with us about his recent PPS experience and his visit from the governor. So over to you, Gary.
Good morning, Dana and everyone on the call. Just a few minutes here. By way of background, we did have a point prevalence testing survey done of our care areas on May 14th. This involved all the residents in the licensed nursing home, the assisted living and assisted living memory care, along with all the associates who work in those areas. So there were about 220 tests done. And this came about really somewhat surreptitiously, I'd say, because we here had been, everyone, been monitoring the data and seeing the prevalence of asymptomatic carriers and what was happening in some long-term care, particularly nursing home settings. So about 2 weeks before the testing actually happened, our medical director, who's on our COVID task force, at my urging, contacted the local health department doctor to discuss testing. And I had then followed up. And it was really, I think, coincident that our calls came at about the time the governor had indicated that, boy, we really should be testing residents in nursing homes. So I would say we were earlier in the queue than might have otherwise happened. So they did come out, National Guard. I think there were about 18 altogether, maybe a few less. I believe they were working in teams of 3, 4 teams of 3. And they had, the way our campus is set up, our health centers in one area, the nursing home, memory care another, and assisted living in another. So they took a team of 3 into each area and went room by room to test the residents. And then a 4th team set up in our outpatient clinic, and we used the exam rooms there for the associates. And they were all scheduled in advance to come and have their times to do the testing, which is really pretty darn quick. And in under 3 hours, the 220 some tests were completed. The novelty in this is that because the governor had indicated that testing should be done, he wanted to recognize the National Guard for their work. And we were notified that the Secretary of Defense and Veterans Affairs, something like that for Virginia, wanted to come out and thank the National Guard, and so did the governor. So they both made a visit to our campus that day, chatted outside, set up outside for a bit. They were all wearing their masks. And then they came inside to the clinic. They did not go to the care areas. So it went very well. The tests all were shipped to the University of Virginia for the results. And they had told us it would take 5 to 7 days to get them back. And I think they were just managing expectations. we actually started getting calls the next day. And I think within 2 days, we had all the results. Because of privacy issues, they could tell us the resident results, but not necessarily the associates on an individual basis because of privacy issues. So they were contacting the associates individually, and the associates, we were asking them to let us know. But because thankfully, joyfully, and perhaps surprisingly, no one tested positive. The health department just told us, we got all your results back and they're all negative. So it was like, oh man, this is great. But this is just a point in time. So we know it could change in an instant. So that was our experience. I'm happy to answer questions if I can. If you want to open it up for questions, Dana, I'll leave that up to you.
Yeah, absolutely. If you have any questions for Gary, if you could please put those in the chat box.
Oh, I need to open my chat box, I think.
Gary, was there a cost? This is Melissa. Was there a cost associated with the testing?
As taxpayers, yes, but otherwise, no.
And what was the response of your residents to the National Guard coming on campus?
Positive. They felt very pleased that we had arranged this and that, the National Guard wanted to do it. Of course, they all want to get tested, even in, the independent living, and we're trying to work through that right now. And the other thing I'll put out there, if anyone has any research information that would be useful going forward, we would like to set up some random sampling and have asked the health department if there is any, data to suggest what the sample size should be, what the frequency should be, so that this snapshot is not just a one and done, but we have some ongoing effort to continue to monitor the well-being of our residents and all the staff that work here. So we're trying to figure that out, for our going forward through this pandemic, just what the science should suggest as far as sampling size and frequency.
So Gary, did you receive 100% participation from your associates, and how did you handle those associates that were on vacation or unable to come in that day to be tested?
Yeah, first, I'll mention the residents. We did need to get consent. You can't just do it, especially involving those that might not have capacity to provide consent. And so we were happy that all family members where they needed to provide consent did so. So we had 100% resident testing, even in memory care, which there was a little bit of concern by some of the children about whether mom or dad would be able to tolerate the nose swab. They get too scared about it, but they all consented. The associates, I think we had 16 that did not come in. Some had called because we're their second part-time job, or they were in finals or away, as you said. So we took kind of a two-pronged approach. If they contacted us and had a legitimate reason, we let them come in to our clinic where we have some test kits so they could be tested and sent those off. If they did not, we made it difficult for them and said, you're off the schedule and you have to go through the health department to get tested, and you can't work until you do. So that all happened pretty quickly. I'd say within 5 days of the results, everybody who hadn't been tested got tested.
And I'm sorry, Gary, I think you might have said this, but I just want to confirm. Was independent living tested or just healthcare?
Just the care areas, the nursing home, the assisted living, and the assisted living memory care.
And I know that you're working on your reopening plans. Have you, or what have your discussions been around staff who take vacation? How are you going to deal with them? Are you going to have them quarantine when they come back, or have you had any internal conversations about how you're going to handle that now that summer's here?
Yes. First, we're not allowing any vacations. No, I'm kidding. If they are traveling, we've talked about this with our medical director, and things, shift a little bit from, worry about planes and trains and automobiles being a little safer, but it's where are they going, and, the prevalence is everywhere now. So we are asking folks to get tested. We made an arrangement with LabCorp, so we have some test kits. And if people are going away and come back, the same is true for residents in independent living. If any of them are going away, they come back. We ask them to self-isolate until we get the test results back. But as soon as they return, it's like, get tested. So far we haven't had any hiccups, but I'm sure we will.
And what is your conversation with the governor like? Did you share our concerns?
I'm sorry, did I share our what?
Did you share any concerns that we have around testing or PPE, or was it, not to put any pressure on you? I was just curious what the conversation with the governor was like.
No, well, first I'll say he was very affable and complimentary. Mentioned, he knew the Westminster Canterbury and Richmond and Virginia Beach, where his mother almost went to live. This was his first time here, and he was talking about the grounds, blah, blah, blah. And he was asking our experience, how many cases, how it was working. I thanked him and encouraged him for the leadership he was providing, and that, this testing was so critical. I did not talk about PPE, but I, did reinforce the importance of the testing and the availability of testing. And he just commented that he understood how important that was. We made a golf date. Other than that, no, just kidding.
I think you said this, Gary, but just to clarify, was his visit prompted because he knew the National Guard was going to be at your site to do the PPS?
That's correct.
Okay.
I didn't say today, but I said here that we just need to remember the perspective that we're the backdrop. This is about the National Guard and recognizing the National Guard and the testing initiative. We just happen to be the site.
Okay.
So we don't want people running up to the governor trying to get selfies and stuff like that. No pictures. We're just, as I said, the backdrop for what's happening.
Well, thank you, Gary. It's 11:15. I know that you had just a few minutes to spare, and we came in right at our time. So thank you so much for being on the call today. And
Happy to.
Back to you, Dana Parsons.
All right.
Thank you so much.
Bye-bye.
Thank you, Gary. So now we have our Virginia Hospital and Healthcare Association update with Kelly Parker. Thanks for joining us today. Kelly, if you're on the line, I think you have to hit *6.
Yeah, thank you. Can you all hear me?
Yes.
Great. Thank you, Dana. Good morning, everyone. I will just provide some brief update on the numbers that we have as they're reported through our VHA system. So through our hospitals, as has been relatively consistent over the last month and a half, we have 1,459 confirmed and pending hospitalizations. Of those, 390 patients are in the ICU, 203 of them are on a ventilator, and total to date, we've had 5,367 confirmed COVID patient discharges from our acute care setting. Our ventilator availability remains consistent. We're only at a utilization rate of about 20%, and we don't have any facilities that are reporting any needs at this time. From the long-term care facility status board update, we have facilities have reported 1,426 confirmed COVID residents and 297 pending residents. And we have 23 facilities that have reported difficulties obtaining PPE in the next 72 hours. Cumulative recovered is a data element we started collecting a couple of weeks ago. And we have a total of 816 confirmed recovered residents in a long-term care skilled nursing facility setting. And that is based off of an 88% response rate based off of yesterday's VHOS update. That's all I have. I'll be happy to answer any questions.
A question came in, Kelly. Why is VHOS requiring 2 negative results to consider a resident recovered?
I'll have to go back and look at the data. I don't have the system pulled up in front of me right now in terms of what the definition is, but the definition that we put in there was consistent at the time with the CDC guidance. So I'll have to review that, and if it's changed, we have not updated our verbiage.
Okay, well, are there any other questions for you? Put those in the chat box.
No more have come through, Dana.
Okay. Thanks so much, Kelly, for the update. We hope you can stay on if there are any other issues or questions that come up. We always appreciate you all joining us with these updates. So now over to you with Sarah Lineberger with the Department of Health.
Sure, can you hear me?
Yes, we can hear you. Thank you, Sarah.
Good morning. I'll just give you some updated numbers from the VDH side. So in Virginia, we're over 40,000 coronavirus cases now, and over 4,500 of those are in long-term care facilities, including 731 deaths in long-term care facilities for this pandemic. And in terms of the outbreak data, which is also on the website, we've had 330 outbreaks of COVID-19, and 192 of those have been in long-term care facilities. Again, that is inclusive of SNFs and ALF. So we're still seeing about 58% of outbreaks are occurring in long-term care facilities. Although anecdotally, the outbreaks seem to be slowing down a little bit in nursing homes. And what we're trying to do right now at VDH is just really figure out how we're rolling out the CMS guidance, both from the EPI side and the licensure side. And so more to come this week from VDH on that. And that obviously that CMS memo from the 18th focuses on skilled nursing facilities, but we're also working to develop some guidance on reopening for assisted living facilities and independent living. So we've been hearing a lot of your questions around that. And I'll just mention, I think he probably already got off the call. Gary probably already got off the call, but in the point prevalence survey guidance that we have posted on the VDH website, which I believe is from May 14th, we have a couple of different point prevalence survey strategies that are outlined. One is to go in and test everyone, all staff and all residents at the same time. But there's a second strategy that we haven't talked a lot about, but that we laid out, and this could be considered for some facilities who would like to, like you said, continue to do point prevalence surveys moving forward, and that's where you choose a random sample of 20% of residents and staff to be tested. And so there's more information. I can put the link to that document in the chat, but there's more information about that sort of random sampling idea.
That's great, Sarah. Thank you. I know first, thank you for mentioning that VDH is working on the guidance for reopening. You know, we're hearing from members that are hungry for that. So we look forward and, you know, are happy to help in any way we can. That's a question that's come in for the members, so I'll ask that later. But with regards to the testing, Sarah, I know that there's a lot of confusion around PPS, and we've talked about this before on the call, PPS, and now this random sample testing, as well as the guidance to test everybody. So it might be too early for you to respond to that, but anything you can share around the goal to test everybody, including staff, on an ongoing basis?
Yeah, so the CMS guidance, it's a good question. The CMS guidance does lay out the idea to test staff weekly over a 6-week period through phases 1, 2, and 3. And so that would be testing of all staff. And we've been having a lot of discussions at the state level about funding around that recommendation. So I think more to come on that, but that would be testing all staff every week.
Great, thank you.
Thanks, Sarah. Are there any other questions for Sarah? Well, thanks so much for joining us. It's a great segue into our next discussion, which is Michael Shaw, from the Executive Director at Cedarfield, who has been working on developing a reopening policy and has going to share that information with us today. So over to you, Michael.
Good morning. Can you hear me?
Yes.
Thank you, Melissa. Thank you, Dana. Good morning, everyone. Before I start, just from one colleague to another, just to thank you for all that you do. Honestly, one of the things that lifts my spirits every day working in the Commonwealth is just the mutual respect and the professional spirit across organizational lines. Yours truly has worked in a couple of markets in the country, and there's something special here in the Commonwealth that I don't think we should all take for granted. So thank you for everything that you all do to be transparent. By no means am I on the agenda certifying that Cedarfield is any type of expert in reopening plans. I believe we're all familiar with the complexities of drafting a phase 1, let alone trying to implement phase 1 at our campuses. But we've had the luxury here at Cedarfield on drawing on some expertise. Mainly, we utilized the federal guidelines produced from the White House, certainly the governor's state guidelines. If you haven't met folks at the Department of Health level, Dr. Danny, Melissa V, Rebecca Lewis, incredible expertise and flexibility in answering all of our questions. So I would strongly advise you to reach out to one of those 4 folks. In addition, in the city of Richmond, again, just leaning on across organizational lines, we all learning from each other here, Westminster, Canterbury, and Beth Shalom, Lakewood and Covenant Woods, to name a few. Cedarfield's part of a family of communities around the Commonwealth led by an organization called Pinnacle Living. So our reopening plan had a lot to do with drawing on some very smart executive directors around our family of communities, in addition to the folks that at our management office called Pinnacle Living. So we came up with a reopening strategy, and we really wanted to focus on 2 things, it being a very collaborative approach, because without the resident buy-in at Cedarfield, really nothing moves forward. So we really involved our resident council. The council worked through 17 different committees, along with the executive leadership of the campus. And it was really a top-down approach, meaning from the servers, housekeepers, all the way down to the executive leadership. We really tried to involve everyone in the plan. And what we learned after 2 weeks of serving people was there's just an enormous amount of trust that needs to be committed to from every individual in order for the plan whatever plan we were to come up with to be executed faithfully. And so that launched into another, I'm sure we all have mission statements and values in our organization, but it led to another drafting of a mission statement and 10 values, which I forwarded to Melissa and Dana, if anybody would like a copy of it, or if you want to call the community, feel free to. And that was the genesis of forming our 3-phased plan. We came up with a mission statement of keeping everyone safe and developed 10 shared values, wearing masks, physically distant, taking personal responsibility, highlighting safer at home practices, infection control, and a couple others, just name a few. And that was really like I said, the genesis that helped us form the first, especially the first phase, but all 3 phases. Amy Chapman, who's now an executive director down at our Hermitage campus, came up with an awesome format that all 5 of our campuses have used. If anybody would like that format, it's just an awesome format that outlines all 3 phases. And so that was the backdrop. We really wanted to concentrate on paralleling what would be our 3-phased plan called Cedarfield Forward with our evolving preparedness plan. So not if or when it strikes again, this COVID at our campus, that we're able to kind of suspend the 3-phased plan and then jump back right into the evolving preparedness plan. But moving into phase 1, one of the biggest things for us was contact tracing. And so if you walk around Cedarfield here today and tomorrow, you'll see lots of sign-up sheets so that we're able to, if there's any other surge that happens on the campus, we're able to contact trace very quickly. And then just to add a little levity to the situation, we're calling it Cedarfield Pledge. We're pledging, we're asking every team member and every resident at the community to pledge to this mission statement and shared values, and hope that people will not only live up to the shared values here at the community, but also take these shared values within their home and or their families and let them know what they are holding themselves up to. So that was kind of the overall strategy. Services through the lens of this mission statement and these shared values, we, in concert, we really wanted to ease and gradually move services into a 3-phased plan, with the absolute idea that once we get to phase 3, that there's a new normal until there's a vaccine that's made. And so we took into consideration a lot of the sizes of the rooms, the participation that would be able to be socially distant in all of these rooms, and then certainly scheduling. So if you've ever been at Cedarfield, our billiards room compared to our chapel are 2 entirely different shapes, and we're able to get a little bit more folks into a chapel than compared to our billiards room. So there's many services that are still offline because of just the sheer size of the room just doesn't even allow for socially distant protocols to take place. So dining, and if anybody would like to see this plan, I'd be more than happy to just forward you the whole plan rather than go into line item by line on it. But it takes into consideration many administrative elements, dining services, talks about a phased plan. We learned from Westminster Canterbury about their phased plan of how to maybe just take a week or 2 of assessing accommodations, apartments or cottages, and then gradually easing into cleaning, and finally maybe doing some deep cleaning maybe into phase 2 or phase 3. But again, this plan takes into consideration the pool, fitness centers, the spas, all the activities. So response to the plan thus far, I guess we're a little microcosm of society. Probably 10-15% think it's too liberal. On the other side, probably another 10-15% think we need to be a little bit more conservative. But we were just talking on a call this morning. there's probably a healthy 80% that think it's a balanced approach from residents, families, and team members that we're on a good path. Two other things that Melissa asked me to touch on was contingency plan. We've had an evolving preparedness plan since, I can't believe we're going into our 12th week here, since the first week in March. And we have really worked closely with the Department of Health and have learned, like I said before, from our surrounding friends and other communities. So we really feel confident that the preparedness plan that we have been working on all along, we've never closed the book. We're able, if there's a surge again here at the community, we're able to utilize that plan and jump back into what we had in place back in the beginning of April. And speaking of a PPS, if any of you are considering a PPS, there's somebody at the National Guard, should probably kill me for saying this, Lieutenant Colonel Sam. She is we had a PPS here as well, and she spearheaded the whole PPS. She is unbelievable. She was a DON, an infection control nurse in a long-term care setting, and she reviewed our entire plan, and a team of her with 4 people actually reviewed the entire plan. So I don't know if you can request a commanding officer, but if you can, she's just unbelievable. So and then one of the things we learned here about testing, we're using a time-based strategy right now. Our friends at the Department of Health have educated me that the better thing to do right now, because testing is not massively available for as often as we would really need it per shift, per employee, is infection control. And we have just gone in a laser-focused approach about infection control in IL, AL, and the health center, to the tune where we didn't have an infection control director, and we promoted a nurse within the ranks to take that lead. And I think it's made all the difference in the world. So
Michael, thank you. Thank you for sharing this and being on the call. One of the questions that came in was, is there anything in particular that you think is innovative about your plan? I would say it's innovative that you have a plan, because so many other people are trying to figure this out. But if you could just share your thoughts on that.
I don't think anything's terribly innovative. I am just in awe of, again, going back to that trust thing I said in the beginning, it just takes an enormous amount of trust to implement something like this. First, develop it. And I think I wouldn't call it innovative. It just all goes back to relationships and drawing. Our residents are, along with everyone's residents, they're very accomplished. They've done many great things in their life. They've seen much worse than COVID-19. And just drawing on the expertise of everybody is probably the most innovative thing I think we have done, is just leaning on everybody to involve people in the plan has made, in this just a short amount of time, in less than 1 week, just the feedback we're receiving, just the calls from the family members coming in and saying, just thank you so much for listening to my mom or my dad and taking into consideration the things that they have said to put that into the plan. That's probably been the overarching thing.
So I know that some of the specific questions, and Michael, if you're willing to share the whole plan, people are asking for it. So if you could send it to us, we can get it out. But specific questions that we've had, 3 areas. One is salon and or fitness facilities. The second, obviously, is dining. And the third is visitors. So just kind of what have you sketched out with regards to each of those areas?
So the salon, the Department of Health has just awesome standards. So we just asked our salon contractor to comply with DOH's standards, which are incredibly thorough. And so So that's what she's doing. It's by appointment only, no more than one resident in the shop, in the waiting, simple things. In the waiting area, there's 2 chairs in the waiting area that's socially distant. But the technician has to wear a mask. The person getting their hair done has to wear a mask for the time that they're not cutting around that little area with the band around the back of their head. So in this plan, there's a link to where the Department of Health has these standards, and they're really just great standards. My mom was a beautician. I forwarded them to my mom. I said, "What do you think, Mom?" She's like, "Oh my God, these are great." So, what was the second area?
I'm sorry. Anytime we can get affirmation from our moms, it's a good thing, right?
Yes.
Fitness, dining, and visitation.
Fitness, we just opened a fairly large fitness center here at Cedarfield. So even with that, we're limiting it to 2 people in that space at any one time with one of the trainers in there, just as a double check and as a monitor. And the pool as well, we closed our locker rooms, so we didn't have to keep disinfecting the locker rooms. So they're actually closed probably through phase 3, quite honestly. We haven't even talked about that. But there's the pool itself, there's 2, we have a lap pool and an exercise pool. So in the lap pool, there's 2 folks that have at 30-minute increments that can sign up to swim laps. And in the exercise pool, we're not doing exercise classes in that pool, but if people want to sign up just to bob up and down and do their own swimming in there, they can as well. So there's 3 people in the pool area. And then visitation is probably the hardest one. Holy smokes. So what we just got off a conference call this morning. On the license side, we're not really allowing visitors to come back to our community even with masks until phase 3. During this first phase, the maintenance department, very creative bunch, they created little hand washing stations for us back in March. I'll show you pictures of them, but they're coming up with a visitation vista, so that we can schedule family members to come, whether the individual's in memory care, assisted living, or the health center. On the IL side, again, this goes back to trust. We have, at one point, we were telling residents that they couldn't leave the county, and we would allow IL folks to leave Cedarfield as long as they didn't leave the county. If they left the county, then they went on a 14-day quarantine. We still have a 14-day quarantine protocol, which surrounds the ER visit, if you're inpatient, and or depending upon where you're traveling. And I can show everybody that little list. So in IL, we've opened it up because in Riker this didn't make sense for the residents here that we're so close to Chester or Goochland. So we opened that up a little bit. And then, so the residents that don't have cars, we have a very tight process for a visitor to come on campus to pick that person up, socially distant, because you're not socially distant if you're in the front seat. So residents know how to socially distant themselves in a car as well. And they have a sign up. We have a sign up for that, for folks to come, for a loved one to come pick up the resident here and then take them to a restaurant or back home for a meal. And then they take with them the shared values and the mission statement so that they can all practice that in that house. Am I making sense?
You are. Sorry, I was on mute. No, I appreciate all this and know that it's a work in progress for everybody. And just, so the question came in, Michael, when does phase 1 begin?
We launched it last Thursday.
So you're in phase one.
We're in it.
And I'm assuming you'll just course correct as you go along, right? As needed.
Absolutely.
Yeah, agility is so important right now.
It is. Yeah, we're constantly testing people. So, as precautionary measures, the physicians and the clinic here is out of an abundance of caution. Just if somebody's just not looking right, we're asking the Department of Health for a test. So we're constantly doing tests. We haven't had a positive now for 6 weeks, and or folks are completely have cycled off of our list that were positive 8 weeks ago. So that's our one dashboard item. If something pops up, then we go back to pre-3-phased planning, and we go back to what we had here in March and April.
Another question came in, Michael. Since the governor hasn't opened fitness centers, how are you getting around that?
The governor hasn't. Okay, I'm not aware of that. My apologies.
Yeah, I think they haven't. He hasn't opened private gyms, but Dana or Sarah, so we don't get Cedarfield in trouble. Thoughts on this?
Yeah, I think I don't want to speak for the Department of Health, and I'm not sure that the fitness center within a retirement community might fall into the same kind of category that the governor is placing that into regarding a phase-in approach. Is Sarah still on and could comment on that?
This is Sarah. I am here. I was looking for the Barbershop Guidance that you referenced. It looks like it might be through DPOR, Department of Professional and Occupational Regulation. I don't know if that's what you were referring to for that, because VDH hasn't put out any guidance about beauty salons.
Yeah, thanks, Sarah. I was looking on the website. That's why I sent you a message. I couldn't find it either. Thank you.
Hey, folks, this is Dee real quick. I'll just drop you the link here.
Here, I got I'll forward you the link as well that I'm referring to.
Yeah. Oops.
In terms
did I say Department of Health? I'm sorry if I did. It looks like this is a Virginia.gov website that we're using.
Okay, thanks.
Yep.
We'll share that in our update today.
Okay.
Go ahead, Sarah.
Go ahead, Sarah.
I don't think the gyms specifically are referenced in the CMS guidance for reopening. But I agree they haven't been reopened in phase 1 by the governor. And then also just to note that CMS guidance basically says that a nursing home should be 2 weeks behind the community for reopening. So most of Virginia's in phase 1. So then a nursing home would start phase 1 of their reopening starting 2 weeks after the community. So like this Friday, a nursing home that's not in Northern Virginia or Richmond could start phase 1 of reopening.
And I know that Jody
that's a good point. At Cedarfield, we're not even, a lot of the things I've just referenced talk about more of things that are in IL. And so we haven't even, all of what I just said does not even apply in the licensed areas except for that Visitation Vista.
Yeah, and I do think independent living is different. And so I do think it would make more sense for independent living to follow more of the community schedule.
Yeah.
Thanks, Sarah. We appreciate the clip. I'm sorry, go ahead.
Yeah, just in terms of skilled care, they should be 2 weeks behind the community.
Yeah, I think what you're hearing from our members has been really on the independent living side, since they have been, at this for, as Michael said, 10 to 12 weeks. So I think that's something for us all to keep in mind, that everything Michael's talking about is for independent or residential living, and we're not even there with AL and nursing.
Right.
Michael, thank you so much. We don't have any more questions in the chat box, so back to you, Dana Parsons.
Yeah. Thank you so much, Melissa Andrews. We are lucky to have Dee Percoin on with us from LeadingAge National, and I wondered if she might have any comments based on what she heard regarding Michael's presentation.
Hey everyone, and good morning, almost afternoon. Thank you so much for the invitation back, and again for everything you're doing every single day to deal with this coronavirus immense challenge. Yes, I was able to join just as Michael was talking through some of their phased reopening, and it is part of conversations that I've been party to all over the country, and have some different things I can share now and then later more in depth if you would like. Just getting into that fitness question for a moment, and it may or may not be helpful to you, but I did drop into the chat the Virginia state guidance on reopening fitness centers, and CDC also has guidance for pools, parks, and recreational facilities. That's the tough thing with independent living and with life plan communities, is if it's not one of the regulated areas, we kind of have to pull pieces from different areas to make this, this quilt of a solution for our particular campuses. One of the things that we and I apologize, by the way, you're probably hearing all kinds of background noise. I am right next to a very busy highway in Reston, Virginia. And so if you hear loud noises, I apologize. So just the end of last week, we posted this resource. I'm just dropping into the chat now. These are 3 different toolkits talking through these issues of reopening. And again, as time permits, maybe later on we can get into more detail. But the first one is really a roadmap for recovery, and it gets into some of the core questions and decision-making points that members are talking about as they're building their plans. First and foremost, knowing what your state says, and I did put together some resources today for Virginia. You may have already seen all of this. I'll just share it in case it's helpful, because a number of members have talked about really going back and using their state language to guide, or also to reinforce some of the decisions that they're making about reopening or not reopening. So here in the chat is the general reopening guidance, and then some excerpts from different sources in Virginia on language about vulnerable older adults. In this case, it talks about staff, but you could easily apply it to residents, and limiting exposure while being compliant with ADA and the Age Discrimination Employment Act regulations. As I've mentioned on other calls, I really see members taking really one of 2 primary approaches with their campuses and liberalizing some spaces. One would be allowing residents movement on and off campus to go out and about, as Michael was describing, for local travel, local trips, and come back and not have that quarantine requirement anymore. But still keeping amenities on the campus closed. On the other side of the coin, I've heard members saying, well, we're not going to let residents come and go, at least not without having to quarantine, but we're going to start opening up some more of our campus amenities. And as Michael described, some are doing a bit of both. One of these roadmaps, the next one after these series of questions, is a matrix on some of those operational areas. At least the ones I'm hearing people talk the most about. What are the operational issues? What are some guidance from the Fed and state? And what should employers be thinking about? The number one area I hear people talk about is dining rooms, for obvious reasons. I mean, and I think there's no argument that we're making sure our folks are all well fed, but what people are really missing is that socialization experience and that sense of getting back to normal. So I've talked to a number of members who are looking at a phased approach similar to what Michael has described and what a lot of the states are doing for their dining room, and phasing in operations as we go, maybe starting off with enhanced takeaway options or enhanced delivery of different sundry items that might be of interest to residents, then working your way into, using outdoor spaces for socially distanced meals, maybe cookouts together, happy hours, virtual events where you could do a cooking class with a chef, for example, and have things delivered, and everything in between, just to help offer some of that social experience without maybe opening up yet to have things back to normal. I'm going to just drop into your chat some other helpful food service related guidelines. These come from all over the place. We have CDC, we have FDA, we have CDC has also a restaurant opening decision tree, as well as food and grocery deliveries. And then Virginia does have restaurant guidance, so I gave you that. And I also included South Carolina because they have a really interesting hotels reopening set of guidelines. I know we don't run hotels, we run residences and homes and operating within those homes, but the hotel guidelines might be helpful to you if you take away the fact that, you're not renting by the night, you have people living there. They have some great suggestions for your interior spaces, public spaces, movement of people in those public spaces, because hotels have a lot of the same types of public spaces that we have in life plan communities. Just to keep going on that same matrix, you'll see chapel, pool, and fitness, which we were all just talking about, spas and hair salons, and Michael pointed that out beautifully. Virginia has a really great resource for reopening your spa. So I'm going to drop links in the chat for those sets of spaces. With chapel, pool, fitness, you could apply a lot of those to other group gathering spaces like wood shops, art centers, and so forth. With salons and spas, a lot of members have said exactly what Michael just said, which is we're going to go by what our state says, and if our cosmetologists can pull it off, then we'll do it in our space. I also included Maine's because I have a really nifty checklist for reopening that might be helpful to your cosmetologist in Virginia. In Maine, I actually had one member say they had talked to their contracted cosmetology service and they had elected not to reopen because that cosmetologist said, I can't really follow these guidelines in that space. There's not enough room, or the disinfection protocol were just too onerous. So it's really good to have that dialogue with whoever your provider might be. Again, just in the interest of time, I'm gonna dump a bunch more links in there, and then we can always talk more. Outdoor spaces, trips. I've heard a lot of members use these as compromise areas to use instead of some of the enclosed spaces on campus, letting people start to use that pergola again, or do scheduled times in the garden like Michael described in the pool or the fitness center. Outdoor recreation, outdoor fitness classes, outdoor concerts. They talked on the national call yesterday, our speaker, about having a roving musician and people would come out and listen on their balconies. I also included construction in the links just now. I couldn't find anything specific for Virginia, but DC does have a decent website on construction, because many of you were in the middle of construction or finishing a construction project and how to resume. And it's helpful really for two reasons. One, just to get your own project restarted, and two, I've had members say, but our residents are saying, well, the construction guy can come and go, why can't my family member come and go? So it might be helpful to be able to go back to those guidelines and have your rationale for why you made that decision, if that's your choice. And then workplaces and spaces, OSHA, CDC, and Virginia all have some great general guidelines. Lots more I could say. The third handout really gets to exiting and entering campus from a resident perspective, from permitting entry to additional service providers, to visitor, loosely visitors like family or others that are not maybe conducting a service, and then moves. And any of those four quadrants, I could definitely talk about more in depth at some time if you would like. But the idea is, communities are trying to find a balance between these different types of movements of people. And it's highly dependent on, what's going on in your state, what's going on in your county in terms of COVID spread, and of course your campus. So that's just a real quick overview, and I'm happy to say a lot more. I have resources from all different states now that I've put together on industry guidelines. So if you're looking for something specific that Virginia doesn't offer, feel free to reach out to me, and I could probably find it for you from another state. I'll just drop my email here in the chat, and then Dana and Melissa, I'll send you this. I have all of these links in a document that I can send to you for Virginia. That's just
That'll be great. We'll
Sure.
include it. Yeah, we'll definitely include those in our update today.
Thank you, Dee. There are no questions in the chat box that I saw for Dee, but lots of wonderful resources. And I did put a question in the chat box around these weekly calls. So our members who are on the phone, if you could just shoot Dana or I an email and say, do you want to continue weekly? Is this helpful? Do we want to try every other week? Is there some other methodology for connecting members and bringing you resources that would work better? We just want to continue to make sure that we're getting you the most meaningful information and data and guidance as soon as we get it, and want to make sure we're using the right vehicles. So just any feedback you have on our support to you during this time, we would appreciate. You can email either or both of us. Thank you.
Thanks, Melissa. And thanks everyone who was on the call today and for our presenters. I just want to point out that our next call for next week is at a different time, June 3rd at 10 a.m. Also, I mentioned that CMS is having a webinar on Thursday at 4 o'clock on infection control. I sent that information to everyone earlier, so I think that'll be a helpful webinar to be on. So thanks again, everyone, and we look forward to talking with you next week. Have a great rest of your week. Thank you, everyone.